Can we get the other speaker who just joined to test his mic?
Okay, I think we're all set. Let's go ahead and get started. Thank you for joining us for Medical Grand Rounds. I'm David Schwartz, Chair of Medicine. This presentation is going to be recorded for future reference. You'll be muted during the meeting. However, you should use your chat box at the bottom of your screen to type in your questions. We'll be collating your questions in my office, and
David,
I'll be asking
muted.
for speakers your questions as we move forward with the presentation. COVID-19 is the challenge and also the opportunity of our professional life. These COVID-19 focused medical grand rounds represents one
David,
of the...
you need to unmute.
Am I not muted? Am I muted? Oh,
No,
we hear you fine. To carry on.
Now you're muted, Dr. Schwartz.
David, you were not muted before, but you are mute now.
Okay. So today we have three excellent speakers to help us understand lung disease and its underlying biology. Ivor Douglas from Denver Health will speak first and discuss the unique features of COVID-associated acute respiratory distress syndrome. Mercedes Rincon will discuss interleukin-6 in the lung. She's from the Department of Immunology. And Charles Dinarello from the Department of Medicine will put all of this in the context of the cytokine storm and offer some potential therapeutic options. So Ivor, I'm going to turn it over to you.
David, good morning, and thanks to you all for joining Grand Rounds. I'm going to focus in the next 10 or 12 minutes on the clinical and pathophysiologic presentations of COVID-ARDS. And just to start off, I'll remind you that it was just a very short while ago.
Let me just interrupt for 1 second, Ivor. Could everyone please mute their computers? Thank you very much. It will prevent the echoing. Ivor, why don't you go ahead and start over again?
David, thank you. I'll just remind us all that it was a few short months ago that pulmonologists were getting very excited about a condition called e-cigarette-induced acute lung injury, E-Valley. Around the same time, those of us in the ICU were battling one of the worst influenza epidemics of the decade. And just shortly thereafter, colleagues in Australia were confronting some of the worst environmental smoke exposure-related lung injury. Boy, how the world changes in just such a short space of time. Let's take a step forward on the next slide and just reflect a little bit on where we are. David, if you would advance the slide, please. Clearly, in a very short time, the focus of our entire community, both clinically and in the broader community, has been on the progression of severe SARS-CoV-2 infection to COVID pneumonia, and in a select number of patients to acute respiratory distress syndrome, with inexorable progression in some patients to multi-organ failure and death. And I simply, through this slide, want to convey really the most sincere appreciation for the tireless efforts of all of those across the academic centers, obviously in the nation and internationally, who literally have put their lives on hold to address this emerging pandemic. I'm not going to be speaking a great deal about clinical treatment today, but really want to focus on the disease states. And if we can go to the next slide, please. I'll remind everybody that the broad clinical diagnosis of ARDS rests on three primary clinical criteria and one measure of gas exchange. Under normal operating circumstances, we've been quite comfortable to diagnose ARDS as a disease that is onset within a week of an inciting event or illness, associated with typical bilateral opacities that are not explained by some other cause. and the cause of which is believed to be non-cardiogenic pulmonary edema in its most part. We have learned that by estimating the fraction of inspired oxygen as a ratio to the partial pressure of arterial oxygen, and I'll refer to that for the rest of today's discussion as PF ratio, in patients receiving a little bit of positive end expiratory pressure. We can just slip back one slide, please, David. We can discriminate three disease severities: mild, moderate, and severe. Unfortunately, that entire paradigm has fallen out with our emerging understanding of COVID-19. And I would therefore like to reflect on an emerging understanding of some disease-specific phenotypes here on the right-hand side of the slide, which have been better characterized of late by Carolyn Calfee and Katie Famous from the UCSF group, which has been more informative as we go discuss COVID-19 ARDS, in understanding that the pathobiology is probably far more important when it comes to differentiating both the onset and progression of the disease. In their work, they focus on two broad groups of illnesses. One they term hypo-inflammatory, with a 20% mortality and the more common, and a hyper-inflammatory with a 40% 90-day mortality rate. The differentiating characteristics of which are these biomarkers and clinical features that you see on the side. In patients with the hypo-inflammatory, low levels of circulating interleukins, including interleukin 6 and the soluble tumor necrosis factor receptor 1, as well as lower bicarbonate and less vasoconstricted treatment is associated. And I'd ask us to bear in mind as we discuss the manifestation of COVID-19 ARDS, just how potentially unhelpful our classic Berlin criteria are, and how much we will begin to rely more and more on the inflammatory phenotype to understand it. Let's go to the next slide, please. We spent time at last week's grand rounds thinking a little about the progression of the disease, and my intent today is not to do any more than just briefly recapitulate the idea that the progressions from the viral response phase through the host inflammatory response phase, stage 2 is being described as the pulmonary stage prior to hyperinflammation, is inexorably in some patients associated with progression to organ failure, including ARDS. I should also emphasize that in a larger number of patients, the viral response is effectively curtailed by the host inflammatory or host immune response, and hyperinflammation is not a feature. For today's discussion, let's focus then on the right-hand side of the slide, and we'll hear from my colleague presenters in a little while their thoughts about how we measure that activity and some treatment responses. Let's go to the next slide and think a little bit about what we're seeing in two broad cohorts. The first I'm going to touch on is a very recently published experience by colleagues Grasselli and co-investigators. These are the heroic group of critical care providers in Lombardy, in Italy, North Italy, who have really been battling a very, very substantial part of this pandemic. In their just published experience of a 1-month series of ICU admissions, 1,581 patients at 72 hospitals, a striking number of these patients are dying, and dying with ARDS. Let me emphasize that. In large part, they're not dying of ARDS, but they're dying of multi-organ failure. As many as a quarter have died within the reporting period. The ICU length of stay is biphasic. Some patients present and die early. Many remain in the ICU for prolonged periods of time. At the time of this report, almost 2/3 were still in the ICU. And as you'll note from the gas exchange parameters at the bottom, many patients present with a very low PF ratio, but what you'll appreciate is that that PF ratio would put them in the severe ARDS group and are requiring recruitment interventions with positive end expiratory pressure, the center panel, which are what we would consider to be very high under usual treatment circumstances. In a subgroup of just 16 of those patients, other investigators from the group identified the fact that there is a discordance, a significant discordance, between the compliance of the lung and chest wall and the severity of the shunting, gas exchange abnormality, in a way that's quite atypical for the classic presentation of ARDS. And they have inferred that the primary physiologic derangement is that of a loss of lung perfusion regulation and a loss of the usual hypoxic vasoconstriction, even in the absence of very severe flooding of the lung. And that's really quite contrary to the usual presentation of septic ARDS that I'll show you in a second. Next slide, please. So I wanted to just touch on what we are learning about the histopathology of COVID-ARDS. And this is just one of the case reports that's out there, but I thought the images were particularly useful to really emphasize that there are some features highly common to severe ARDS in general, such as the diffuse alveolar damage, illustrated here with classic hyaline membranes, the pink amorphous material in the alveolar surface. And then, quite interestingly, is the collections of interstitial mononuclear infiltrates, which are predominantly lymphocytes, and there's some effort presently to characterize these, as well as viral pathogenic change, these multinucleated syncytial cells, which are far more commonly seen in viral pneumonia, and from reports very similar to that which was seen in SARS and the Middle East respiratory syndrome, which are also beta coronavirus infections. Let's go to the next slide. So I want to highlight just this really interesting disconnect between the lung elastance, the stiffness measure, and the amount of shunting that's going on, and highlight an emerging understanding that there are probably two broad phenotypes of the disease. The graphs illustrate CT density, where the blue is lower density and the red is higher density components. And you'll see that for the more common L type, low elastance, low VQ ratio, low lung weight, and lower recruitability, oxygenation is very poor. Just the same level of gas exchange abnormality, here illustrated by the H type, PF ratio 84, is seen in a subgroup of about a third of patients who have the classic, very dense, heterogeneous distribution of ARDS infiltrates, illustrated here by much more dense red Hounsfield units on the right of the curve. And these patients, although their lung elastance is high, have a much larger amount of recruitable lung at the post-basal part of the lung. And when I speak a little about proning ventilation in a moment, we'll appreciate that these patients may be at particular, may derive particular benefit from this intervention. Next slide, please. Yeah, there we go. So I want to draw out, because we'll learn in a little bit more, some greater detail about some of the pathogenesis, but highlight that the rather prototypical understanding that we have of alveolar flooding with neutrophil-driven inflammation and leakage of plasma-rich fluid across the blood vessel alveolar barrier, illustrated here at the base of this image on the left from a really important Michael Mathey review, with abnormalities of the sodium-potassium ATPase pump and infiltration through chemokine-mediated inflammation of monocytes, may well only hold in part when we come to the inflammation that is causing COVID-ARDS. To that extent, I'd like to look at the image on the right-hand side, in which an alternative vascular-based injury is hypothesized. And in this syndrome, the phenomenon of viral-mediated activation of monocytes and ultimately the thrombosis pathway at the same time, termed immunothrombogenesis or immunothrombosis, is postulated to be a major driver of the L type of COVID-ARDS. In these patients, alveolar flooding is less pronounced, but disturbances of pulmonary microvascular function are far more likely. And in work from Jean Moore and others that's evolving in this area, a suggestion of abnormalities in fibrinolysis with complete fibrinolysis shutdown and impaired TPA clearance, it may well be a mechanism. Let's go to the next slide. And just to highlight this with one further observation is another pathology specimen showing that indeed microvascular thrombosis is a post-mortem finding in some of these patients. Next slide. So how could we conceive then of the inflammatory milieu and response to SARS-CoV-2 infection? We heard a lot last week about the ACE2 receptor as an important viral mediator for entry. And in this image, courtesy of Vic Tseng, one of our previous fellows, now faculty, Vic has depicted the activation of the interleukin-6 and interleukin-6 receptor-bound responses driving a systemic inflammatory response with an increased pulmonary vasodilatation and ultimately airspace drowning, which causes profound shunt and abnormalities of gas exchange. Now, as I've suggested, this kind of prototypical image might explain about a third of the cases, so-called H cases. Next slide. But it's more likely that there are several different pathways, if I could ask for the next slide, please, David, that are downstream of this response. And I'd like to now propose that, in fact, the alternative pathway, the L phenotype, is really a manifestation of profound disturbances in pulmonary microvascular autoregulation, as well as areas of fibrin and inflammatory obstruction, leading to gas exchange failure, which is as profound, but without the classic alveolar airspace flooding. You could well imagine that the compliance in patients in that L phenotype who don't have as much alveolar flooding is better than when they progress or evolve to the H phenotype. And so I think that as we pursue some better understanding of the biology of this disease, some clear understanding of these compartments of information will be important. Next slide, please. We'll hear more in a minute about the activation of cytokines, as some have termed a cytokine storm. I'm cautious about evoking the macrophage activation syndrome, well characterized here on the left as one of the secondary hemophagocytic syndromes. But we'll point out that elevated ferritin, which is downstream from IL-6 as an induced expression, is very, very typical and in fact potentially prognostic in these patients. Our own Peter Henson at National Jewish has hypothesized that the specific inflammatory response may well be a characteristic of either resident or recruited lung macrophage activation. And that's why this particular phenotype is so marked. Next slide. I will remind us that interleukin-6 is a well-established inflammatory mediated biomarker in all forms of ARDS. Work from Schutte in the mid-90s and Park and Tom Martin from University of Washington, Seattle have both characterized the elevations of IL-6 in the BAL. I would point out the important differentiator here in the closed triangles is primary ARDS on the left side, and you'll note that levels remain significantly elevated compared to pneumonia or cardiogenic edema through day 10. In Tom Martin's work, they express the level of IL-6 relative to soluble IL-6 receptor as a marker of free bioavailable IL-6. And you'll note that the level is less than unity on the 7th day and beyond, suggesting that perhaps in regular forms of septic ARDS, IL-6 levels may be important in mediating inflammation early on in the disease. Next slide. So finally, I just want to touch on what we're doing for these patients in the context of this interesting and very challenging pathophysiology. On the left side, I've depicted our usual care lung protective ventilation strategy, and I'm simply going to contrast our approach in COVID-ARDS to highlight the clinical implications of some of the things I've mentioned. We're actively avoiding the use of non-invasive ventilation, not because it will not improve oxygenation, but we have found that it does not necessarily delay or put off the likelihood of intubation, and is certainly aerosol generating. As opposed to using lower tidal volumes and a lower amount of PEEP based on the FiO2, informed by the ARDS network studies, we are using a relatively higher amount of PEEP to enhance lung recruitment, while at the same time being careful to avoid over-distension. And very importantly, although early prone position ventilation is common at Denver Health, it's not so much at other centers, but we really do urge the early use of prone position ventilation when the FiO2 creeps up above 60 or the PEEP more than 10, and continuation for prolonged periods, days if necessary, without necessarily reverting to supine position would be important. Corticosteroids are contraindicated for complicated reasons beyond this day's discussion. We would recommend consideration of inhaled pulmonary vasodilators, which we don't usually do particularly for L-type. And we have made a decision to avoid forms of extracorporeal life support because they're too resource intensive. Finally, and perhaps I could address in the discussions, our approach to weaning, where we continue to maintain high levels of PEEP, which is quite different from our usual care. I finally want to leave you with a thought about how to approach this. And if we can go to the final slide, please, David. My wife has been reading La Peste, the Albert Camus classic, about a plague in post-Second World War Algeria. And it's a story of a physician confronting a plague not dissimilar in nature, but far more existential. And there are two relevant comments I've found that I thought were relevant to today's discussion. He says, "I have no idea what's waiting for me or what will happen when this all ends. For the moment, I know this: there are sick people and they need curing. What's true of all the evils in the world, and true of plague as well, is it helps men and women to rise above themselves." And I think that we should bear that in mind as we go forth in our work here. Thank you for the opportunity.
Ivor, thank you very much. That was a great talk. We're going to go on to Dr. Rincon now from the Department of Immunology.
Okay, can everyone hear me?
Yes.
Okay. So, following the previous presentation, I think Dr. Douglas made a really good introduction for this. I want to talk about interleukin-6, he already mentioned. And before I start, I want to disclose that I don't have any conflict of interest, but I've been working in this cytokine for more than 25 years. From the beginning, interleukin-6, it was IL-6. It was considered just a pro-inflammatory marker together with TNF, interleukin-1, produced by macrophages. And it was considered because of the elevated levels of interleukin-6 and serum, a number of inflammatory disease like rheumatoid arthritis, osteoporosis. And back 25 years ago, not many people thought that interleukin-6 could actually contribute to pathology of the diseases. But I had to give the credit. I had to give the credit to Dr. Kishimoto in Japan, who actually developed tocilizumab. It's a blocker antibody for interleukin-6 receptor. And he pursued this, thinking that this will be effective for the treatment of some of these diseases. And he managed to take it to the clinic through Sugar, and eventually Roche did all the big trials, phase 2, phase 3 trials. And then back in 2010 or 11, it was approved for treatment for rheumatoid arthritis, and it works in some of the patients, that's for sure. So, what is interleukin-6? Who makes interleukin-6? So clearly, some of the inflammatory cells, like David mentioned before, Ivor mentioned before, B cells, dendritic cells can make, and macrophages can make interleukin-6. And this is the classical view. Every time that we see interleukin-6, we think macrophages can make interleukin-6. However, something that attracted me over already 25 years ago is the fact that interleukin-6 is actually produced by a number of cells. It can be produced by epithelial cells, by fibroblasts, vascular smooth muscle cells, endothelial cells, and other cells. In physiological conditions, there is no production of interleukin-6, but in response to insult, damage, stimulus, then these cells start making interleukin-6. Interleukin-1, one of these potential insults, and you're going to hear from Charles Dinarello later, can promote interleukin-6 production by these cells. And what we know is that the virus infection in the epithelial cells can induce the production of interleukin-6 coming from this. So you can imagine in the lung, clearly you are going to have some macrophages and resistant macrophages, or some inflammatory recruited macrophages. But in the lung, you have many components that are different, that are the main component, which included epithelial cells, fibroblasts, smooth muscle cells. So in the context of respiratory virus, you have other cells that can make interleukin-6 that are not necessarily the macrophages and the inflammatory cells. And when the virus infects the epithelial cells, this replication triggers the production of interleukin-6. As you can see, we have data from influenza virus from a number of years ago, where you take mouse lung epithelial cells, you culture in vitro, and this is primary lung epithelial cells isolated from the lungs from the mice, and you incubate with influenza virus in higher concentrations of the virus, and you can see that the virus induced the production of interleukin-6 by primary lung epithelial cells in a dose-dependent manner. And this requires the virus replication. If you use inactive virus or attenuated virus, you don't induce interleukin-6. Similarly, other groups have shown that SARS-CoV, not COVID-2 yet, I haven't seen it, can induce interleukin-6 production by human lung epithelial cells, similar to I saw influenza. So clearly, SARS-CoV can induce the production of interleukin-6, not necessarily from macrophages, but at least from the infected cells, when the infected cells, the epithelial cells. So you can imagine that within the lung, now you're going to have epithelial cells producing interleukin-6. The more, the better transmission of the virus from cell to cell, you are going to have more interleukin-6 being produced within the lung environment. And then, as Charles will say, with interleukin-1 can induce interleukin-6 production in other cells within the lung too. So the production of interleukin-6 could be very large in the environment within the lung, and not necessarily coming from the macrophage, but with other cells. So why we care about interleukin-6 within the COVID-19? Dr. Douglas already mentioned before, we have now a number of studies, most of them coming from China, because this is where the pandemic started. So they are at least almost 2 months ahead of us. But this is one of the studies that they published from the Wuhan, the hospital in Wuhan. In this case, they compare cytokine levels in the serum from non-severe patients and severe, and they also stratified based in neutrophils to lymphocytes, because most of these patients are lymphocytic. And you can see it's not a typical cytokine storm, because interferon gamma is no different between non-severe and severe, and this is pretty normal. TNF, normally interleukin-6 and TNF, all these cytokines are produced by macrophages, but TNF is not produced, is not elevated, and the levels here basically are the same levels that you would expect in a healthy individual. But interleukin-6, it was really high within the severe compared to the non-severe. This is one of the studies. Then here is another study. In this case, it's a different institution within Wuhan. They compare non-severe versus severe right at the admission time. All the patients have, the severe have increased CRP, ferritin, ESR, and the D-dimer, which are clinical parameters for the disease, so showing that they are severe. There was no really major difference immunologically between the two groups. But now when they look for cytokines, again, interleukin-2 production is normal and no difference. Interleukin-4, no difference. TNF, the other typical inflammatory cytokine, is not elevated. This is normal levels in healthy individuals. But interleukin-6, it was really high compared to the severe compared to the non-severe. And even interleukin-10 is almost an anti-inflammatory cytokine. It was a little bit high, but interleukin-6 levels were clearly high in the severe. And there is another study just came out last week. This is coming from Munich in Germany, where in here, actually, it's a retrospective study, and they compare the patients that all of the patients were admitted to the hospital, but some patients needed ventilation and others didn't need ventilation. So then they look for a cytokine levels in at the baseline before even the patients were decided to take it to the ventilator or no. And what they found, I'm going to go here directly. Again, the patients that didn't need a mechanical ventilation have lower levels of interleukin-6 compared to the levels of interleukin-6 in the patients that needed ventilation. And this is interleukin-6 at the baseline right when the patients were hospitalized. And they follow up with interleukin-6, and when they took interleukin-6 right before intubation, again, the patients have remained high for interleukin-6. And what they conclude is that the risk for respiratory failure for patients within interleukin-6, about 80 picograms per ml, it was almost as it was really high compared to the patients we have lower interleukin-6. And they put like a threshold here, 80 picograms per ml in the serum to consider potential risk. But so these three studies and there are other studies suggest that interleukin-6 is definitely present in the severe disease, and it could be involved, but it doesn't say anything because, again, with these correlations, you don't know whether it's the cause or the consequence. But clearly, interleukin-6 could have an effect. So what is interleukin-6 doing? Well, where we know interleukin-6 recognize interleukin-6 receptor. This is a transmembrane protein present in the cytoplasmic membrane. Interleukin-6 receptor doesn't have much of the cytoplasmic intracellular domain, so it doesn't transduce signal by itself, but associates with GP130, and GP130 is the transducer of the signal into the cell. So when interleukin-6 binds to the interleukin-6 receptor, associated GP130, induce the activation of this kinase, JAK1 and JAK2, and this phosphorylates STAT3, and then STAT3 is a transcriptional factor that is involved in the regulation of a number of genes. And although I'm not going to talk much about today, but STAT3 has been also shown to regulate mitochondrial function. So the classical pathway in the cells that express interleukin-6 receptor, interleukin-6, as I say, binds to the interleukin-6 receptor, which is very specific, and the binding induce the dimerization with GP130. GP130 is expressed ubiquitously by most cells and is also shared by other cytokine receptors. But the interleukin-6 receptor is abundantly expressed only in hematopoietic cells, including macrophage, neutrophils, T cells, hepatocytes. But most of the cells do not express significant amount of interleukin-6 receptor. So this is what we call classical signaling for interleukin-6. But then there is another signaling that is defined as a trans-signaling. And what happens is that the cells that have interleukin-6 receptor, they cleave interleukin-6 receptor through these metalloproteases, ADAM17, ADAM10, and now you have soluble interleukin-6 receptor. And this is certainly is an agonist in a way that when it binds interleukin-6, can associate with GP130 in a different cell. And this, when they associate, it actually induces the signaling. So this pathway is very relevant because when only the cells that have interleukin-6 receptor will respond to interleukin-6, cells don't have interleukin-6 receptor will not. But if you have soluble interleukin-6 receptor, cells like epithelial cells, smooth muscle cells, endothelial cells, these cells respond to interleukin-6. So if you have inflammatory cells like a macrophage, neutrophil, CD4, these cells have been shown to produce soluble interleukin-6 receptor. If you have these cells around, then cells that normally in the physiological conditions will not respond now will respond to interleukin-6. So what interleukin-6 could be doing? And this is a model that I will suggest potentially for SARS-CoV or other virus, respiratory virus, is that you have an infection of the epithelial cells, alveolar epithelial cells, but could be other type of epithelial cells too. This infection is going to trigger interleukin-6. Interleukin-6 is produced. In the context of inflammatory cells, these inflammatory cells can produce the soluble interleukin-6 receptor by cleavage. And now, cells that normally don't respond, again, fibroblasts, smooth muscle cells, endothelial, even epithelial cells, can respond to interleukin-6 because the association of the soluble interleukin-6 to the GP130 and the interleukin-6. So there are a number of functions that have been associated to interleukin-6. I'm just going to list a few here that could be associated, linked to the pathology of COVID-19. We and others have shown interleukin-6 promotes survival of neutrophils, maintaining neutrophils in the lung, for instance. It can promote proliferation and migration of vascular smooth muscle cells, cause endothelial dysfunction, that's well known, can induce fibrinogen synthesis associated with cardiovascular disease, induce collagen production in fibroblasts. It can definitely induce acute phase response, the production of CRP in the liver, and it can also regulate T cell function and many other functions that I don't list here. But you can see some of these can link to some of the features that Ivor was talking about within the disease. Within the last 10 years, it's also clear that interleukin-6 has been associated with multiple diseases. And we know that definitely is involved in autoimmune diseases, and tocilizumab, so the blocker for interleukin-6 receptor, is effective. There are studies associating interleukin-6 with the risk of diabetes too. There are a lot of association with interleukin-6 and pulmonary hypertension and poor survival of the patients with more interleukin-6. With heart failure, there is ongoing trial with tocilizumab in patients with cardiac arrest after they suffer cardiac arrest. We and others have shown that interleukin-6 correlate with asthma and risk of asthma and also in poor lung function, COPD, lung fibrosis, and there's also evidence, talking about kidney before, there's evidence that interleukin-6 is also associated with kidney diseases. So there are a number of diseases that have been associated with interleukin-6. So what about COVID-19? Do we have any evidence that interleukin-6 is actually contributes to the pathology of COVID-19 and not just the result of? So this is the only study that has been made public right now. It comes from China, the Anhui province, and it was done with 21 patients and in 2 different hospitals, and the patients were treated with tocilizumab. It's considered as a trial, but again, we had to be very cautious because this is just single-arm trial, so there was no placebo. They don't compare with other patients that receive other type of treatment. So, as I mentioned, tocilizumab is the antibody blocker for interleukin-6 receptor. And what they found is that out of these patients, CRP, which is, again, a clinical marker, is very high in all the severe patients. Most of these were already, again, severe patients. CRP, it was very high in all the patients, and very fast, within 2 days, 3 days, the levels of CRP basically go back to normal. Tocilizumab treatment also decreased fever relatively quickly, day 1, and it's known that interleukin-6 contribute to the fever. And clinical parameters, CRP we know is regulated by interleukin-6, so this was probably expected. But I think that probably the most promising results are these 2 parameters. They look for oxygen uptake, so basically the need of oxygen from the patients, and is reduced with the treatment with tocilizumab. and the oxygen saturation, which is low in the patients, actually get restored basically with the treatment of tocilizumab. So this is from one study. I said we had to take it cautiously because it's only one single arm trial. We need to have real trials with comparing with other treatment. But what I know from the cases in Italy, they start using this within probably 1 week or 2 weeks of the outbreak of the pandemic. And the patients basically show similar response to this. And I know from colleagues of mine in Germany and also in the University of Vermont, they are treating some of the patients with tocilizumab, and they basically see similar response to what is described here. And there is a suggestion that tocilizumab could reduce the time with ventilator potentially. Again, we need additional studies to confirm that. So, but what are other treatment based on these promising results? What do we have? So clearly, as I said, tocilizumab, Roche just got approved by FDA for starting a phase 3 clinical trial in different sites for COVID-19. Apparently, there is a shortage of tocilizumab right now based on the results from China and also Italy. So this may be a potential issue right now. The other blocker antibodies for interleukin-6 receptor 2 is sarilumab. And sarilumab, Regeneron already got, I think, the approval by FDA for a phase 2/3 trial with COVID-19. So that would be another option to block interleukin-6. And one thing that I haven't seen anything yet, but it could be a possibility, is inhibitors of JAK1, JAK2. You remember I mentioned that JAK1, JAK2 are associated to GP130, are activated by interleukin-6. They are not specific for interleukin-6 pathway, inhibit other cytokines too, but they are these are approved for treatment for rheumatoid arthritis too, baricitinib. And this potentially could be another alternative. This is just a small molecule. This is a regular drug. These are biologicals. And Charles Dinarello is going to talk about after me about potentially the uses of blocker interleukin-1, because as you remember, interleukin-1 can induce the production of interleukin-6 in fibroblasts, in endothelial cells, smooth muscle cells. So one of the things that I want to bring up before I finish is we know we have a lot of patients. We have a couple that both of them get infected with COV-2, with the COVID-19 virus. However, one of them get really, really sick and the other person not. Even probably both have been exposed the same. So my question, and nothing is known right now, is there any potential genetic component that can determine the severity of the disease? And I wanted to mention related to interleukin-6, because this is where I know the best. There are some clear polymorphisms in interleukin-6 gene. This one was identified already in the late 90s. Is in the promoter of interleukin-6 gene, and the G2C, the C is the minor allele, is represented about 20% of the population. And when you have the C, you actually have lower levels of interleukin-6 in plasma. And this polymorphism has been associated with decreased risks of type 2 diabetes. So again, lower interleukin-6, less risks of type 2 diabetes. So this is one. There are other polymorphisms with interleukin-6 promoted, less study and probably less frequent as this one. There is also polymorphism in interleukin-6 receptor gene. And the most common present in the population, and also the more well-studied, is this polymorphism, which result in from A to C, is in the coding region and lead to a change from an aspartic to alanine. And this residue is right where the cleavage of the interleukin-6 receptor happens. So in this case, the C allele is also the minor allele. They estimate maybe 10-15% of the population have CC. But this is associated with increased production of soluble interleukin-6 receptor. And this was identified in 2011, 2012 to be associated with risk of asthma, and within asthma is associated with impaired lung function too. And the other thing I wanted to bring up is two things. We know from mouse and from human that interleukin-6 levels are always lower in females than in males. And this probably nobody paid too much attention, but it's interesting because within the incidence of COVID-19, there is even the incidence of infection is about the same between men and women. Most of the patients that they die are men. It's almost a ratio of 2 to 1, men versus women. So there's something to keep it on mind too, because maybe interleukin-6 could be associated to the severity of the disease and also the levels of interleukin-6, male and female. And finally, is also we know that interleukin-6 is always elevated in elderly people, which in this case are the more susceptible for the severe disease in COVID-19. So overall, I'm going to finish just saying that, again, I think it's clear now that the interleukin-6 levels correlate with severity of the disease in the COVID-19 patients. That this, it doesn't necessarily represent like a exaggerated immune response, a typical cytokine storm coming from inflammatory cells, but it could come from other cells within the lung. And also the fact that, as I say, we have promising results for treatment with a blocking interleukin-6 receptor in hospitalized severe patients. I will not use this treatment definitely early because interleukin-6 also contribute for other aspects of the immune response that is important early on. But these are, again, promising results, and I hope there will be more that we can compare with in a real trial with other treatment and conclude that this treatment is working. And that's it.
Mercedes, thank you very much. That was great. Charles Dinarello, are you with us?
My name is Charles Dinarello. I'm professor of medicine and immunology at the University of Colorado. I'd like to speak to you this morning about the acute respiratory distress syndrome and of COVID-19 and mechanisms of the disease, as well as therapeutic options. As you can see, the New York Times focused on a very important aspect of this disease, and that was the immune system. And they used a term called the cytokine storm, which is perhaps not familiar with non-medical associated people, but it is actually a very important component, not only of COVID-19 infections, but also of other systemic inflammatory diseases, including influenza and other viral diseases that are associated with the respiratory system. During the New York Times article on the cytokine storm and COVID-19, they interviewed one of my colleagues, Randy Crone, who's worked quite a bit in this field. And he said, and I quote, "The cytokine storm keeps raging long after the virus is no longer a threat." And that is actually true. So that's kind of an important aspect of the pathogenesis of the disease. So what is a cytokine storm? It's actually nothing but an unusually high level of circulating pro-inflammatory cytokines that are always associated with organ damage. This is a very critical issue because sometimes circulating cytokine levels are associated with various diseases, like gout, for example, but there's no real systemic organ damage. But with pro-inflammatory cytokines at very high levels, there's an association with organ damage. In the case of ARDS, it's obviously lung damage. Now, pharmacologic blockade or neutralization of specific cytokines can reduce organ damage. As we know from sepsis trials and other trials, we'll use specific cytokine blockers to treat the high levels of these cytokines, specific cytokines like tumor necrosis factor, IL-6 and IL-1, and you see a reduction in the severity of the disease. And in some studies, you actually see survival. The therapeutic options to reduce the cytokine storms are multiple, but this afternoon I only want to focus on the ones that I think are significantly applicable to COVID-19. Top of my list is blocking interleukin-1 alpha and beta with anakinra. I'll explain anakinra a little bit later. There's also blocking IL-6 receptor with tocilizumab, very important mechanism. But I want to talk to you about something relatively new, blocking upstream, very early in the disease with an oral NLRP3 inhibitor. The Chinese actually had picked up on this, the importance of the cytokine storm very early in the disease pathogenesis. In a very early publication, they reported measuring elevated levels of chemokines and IL-18 from peripheral blood mononuclear cells of patients suffering with the disease. It was interesting that IL-6 was not on the list because IL-6 is actually produced from epithelial cells. And you heard this from Mercedes' presentation just prior to my presentation, that the IL-6 actually in COVID-19 is coming from the epithelial cells of the body. But in the Chinese paper, the authors concluded that our data suggests that SARS-CoV-2 infection-induced excise cytokine release correlates with lung tissue damage and the pathogenesis of the disease. And they were correct. They were the first people to actually make this association. And now we are dealing with this, and we're dealing with the issue of how to apply our cytokine knowledge as a therapy. Now, one view of evolving cytokine storm is the mechanism of action. On this slide, I show you the lung, the natural situation of the lung at the time of infection, and then the lung during inflammation, and the role of the bone marrow. So we look at the primary infection. We have virus infection of type 2 epithelial cells. These are the airway epithelial cells. These cells actually have the receptors for ACE2, and the virus infects these through the receptor mechanism, and it results in death of the type 2 airway epithelial cells. It's a lytic virus, so it infects the cells and kills the cells. It obviously releases more virus in the process, but also releases cell contents. And the cell contents include interleukin-1 alpha, which is present anyway as part of the airway, and other cell contents. IL-1 alpha then induces chemokines. Chemokines are small molecules that attract neutrophils and monocytes into tissue. And these are produced from the resident macrophages in the lung. So you have an epithelial cell source of an activator of macrophages. Of the large number of molecules and cytokines that can be produced in the resident macrophages, two are actually very important in the pathogenesis of this disease. This is granulocyte colony-stimulating factors and interleukin-1 beta. These enter the circulation. They go to the bone marrow. And GCSF and IL-1 beta in the bone marrow have a very unique property. They cause the release of immature neutrophils and monocytes, and these sometimes are called myeloid-derived suppressor cells, MDSC. That's just a characterization of early immature forms. It's sort of a rapid response. We see this often in acute viral infections. Very early on, you see a neutrophilia that then goes away later on, but you can pick it up very early in acute viral diseases. The release of immature neutrophils and monocytes from the bone marrow targets the lung because that is where the chemokines are produced, and that's where the disease exists. Now, in the lung circulation, as these myeloid-derived suppressor cells reach the lung, they obviously reach the lung through the circulation, and they adhere to the endothelium. That's their first target. In the endothelium, they open the junctions, and this begins part of the capillary leak syndrome. And then they invade the tissue directly. They go through the junction, they move the chemokines into the lung, and there they start to accumulate and infiltrate the lung through the opening of the endothelial junction, and you have more cytokine production, more chemokine production as these neutrophils and monocytes evade the lung and the numbers increase. And the important issue at this point is the damage they cause, the damage that all these neutrophils and monocytes and additional cytokines are producing. In this process, in this acute lung injury, there are mechanisms that cause release of more cytokines, but particularly I want to point out that the NLRP3 inflammasome, which is part of the upstream mechanisms of the cytokine storm, becomes part of the pathogenesis. Together, these now enter the circulation, and we now measure the cytokine storm as circulating cytokines, but they are derived primarily from the acute inflammation in the lung. Of all the cytokines that are in the storm in the circulation, interleukin-6 is particularly important because interleukin-6 goes to the liver, and there it has this unique property, not only of reducing liver hepatitis, hepatitis in the liver, but also inducing ferritin, D-dimer, and CRP. And these are one of the best markers of disease severity. Increased ferritin, increased D-dimer, and elevated CRPs. These are products primarily of the liver hepatitis that takes place in the disease. And we use these as biomarkers. In addition, something else takes place during the cytokine storm. We're not particularly sure where this takes place, but we know that interferon increases. Now, interferon increases in interferon increases in the cytokine storm, results in going back to the bone marrow, and there they have a property of hemophagocytosis, cytopenia, which is depression in platelets, and macrophage activation syndrome. So macrophage activation syndrome is a lethal clinical situation that develops late stage in the disease. Many, not all, but many do develop macrophage activation syndrome. And macrophage activation syndrome is targeted by either using an antibody to gamma interferon or actually blocking IL-1. We'll discuss this later, but this is the worst case scenario, is macrophage activation syndrome associated with the ARDS of COVID-19. Now, the myeloid-derived suppressor cells, these are the ones that come out of the bone marrow, the immature monocytes and neutrophils, they go to the lung. They have properties that are immunosuppressive, and this is actually another aspect of this disease that Ivor actually discussed earlier this afternoon. Nitric oxide is produced by these cells, it's immunosuppressive. Prostaglandins, very immunosuppressive for T cells. Reactive oxygen species, these are obviously generalized toxicity, not only for the immune system, but also for the lung parenchyma. Obviously, myeloid-derived suppressor cells, particularly since they're myeloid cells, they will produce their own cytokines, including IL-1 beta, IL-6, TNF, IL-10, which is immunosuppressive, and chemokines such as IL-8. Arginase 1 is also immunosuppressive, and the most immunosuppressive is PD-1 and PD ligand 1. And we make that association, of course, with cancer and all the checkpoint inhibitors, which are primarily blocking the immunosuppression of PD-1 and PD-1 ligand. And they all also part of the myeloid-derived suppressor cells properties, the production of interleukin 2,3 dioxygenase, which is suppressive for T cell function. So these are all the properties of the cells that migrate into the lung that are causing the problems, including immunosuppression and inflammation. Now, the cytokine storm is a cascade, and it begins in macrophages in the resident lung parenchyma that express ACE2. The first step is the activation of NLRP3. I'll discuss NLRP3 in a second in detail. But this results in the release of active IL-1 beta, the induction of IL-6 from the lung epithelium. The IL-6 enters the circulation, goes to the liver, and we measure CRP. So that is a cascade that accounts for early activation of NLRP3, and the final product is what we measure, which is CRP. Now, also what takes place is there are ACE receptors. The receptors are on airway epithelium. So on the left, it was the receptors on macrophages. Now the receptors are on the epithelium. This gives you cell death. And the cell death causes the release of IL-1 alpha and HMGB1 and other pro-inflammatory cytokines, again to the lung macrophages, again activation of NLRP3, again active IL-1 beta, and the induction of IL-6 and other chemokines and cytokines in the lung, and the infiltration of immature neutrophils that damage the lung. So either way, you have NLRP3 early in the cascade, whether it starts in the macrophages or in the airway epithelium. In addition, the endothelium is also a source of cytokines. The ACE receptor is on the endothelium and will release cytokines, including IL-1 alpha from the endothelium. There's some reports that urokinase plasminogen activator is also released from the endothelial cells, and this is thought to be a good biomarker for the severity of the disease. Now, what is NLRP3 and what does it do? It's nothing but a very large complex of proteins, very, from an evolutionary point of view, very old, and it aggregates, with a fall in intracellular potassium. It oligomerizes and then converts a pro-caspase-1 to an active caspase-1. Now, NLRP3 stands for nucleotide binding domain leucine-rich repeat pyrin-containing protein 3. But the better way of talking about NLRP3 is the IL-1 beta inflammasome. This term inflammasome is used repeatedly to indicate the inflammation that follows when this molecule is activated by a fall in intracellular potassium. The critical part of the inflammasome is NLRP3, shown in the lower right-hand corner. There's a large molecule that forms aggregates with other molecules, particularly ASC, and the card domain of cardinal. These are names for other proteins, but together they form the aggregate and they activate inactive caspase-1 to active caspase-1. Now, active caspase-1 is a heterodimer, and its primary job is to cut the IL-1 beta precursor, which is inactive in the cell. So the inflammasome converts inactive pro-caspase-1 to active caspase-1, and therefore controls the processes and secretion of IL-1 beta. It cuts the inactive IL-1 beta precursor into a pro piece that gets ubiquinated, and the active molecule is released from the cell. Once the active IL-1 beta is released from the cell, it stimulates IL-6, and we see the cytokine storm. So what really can take place therapeutically very early on is to use a drug that inhibits the NLRP3 inflammasome by targeting specifically the domains of NLRP3. And a drug called dipansutriol actually accomplishes this very specifically. It very specifically binds to NLRP3. Some people call NLRP3 cryopyrin. But the important issue is there is a drug that specifically binds to the NOC domain of NLRP3 and prevents the aggregation, prevents the activation of caspase-1, and prevents the ability of caspase-1 to cut the IL-1 beta precursor into an active cytokine. It's a very small molecule, as shown on this graph, and it inhibits IL-1 beta production, does not inhibit the production of the IL-1 precursor. It only works by inhibiting the processing, the activation. So it's highly specific. It's actually, mechanism of action was actually done in our laboratory here at the University of Colorado by our group led by Carlo Marchetti. Now go back to what the therapeutic options are. On the top, and first and most importantly, is NLRP3 itself. And then after NLRP3 is anakinra. This is like the order that probably should be considered in dealing with this. So early it's NLRP3 inhibition, then anakinra, then anti-IL-1 alpha, then anti-IL-1 beta, and then anti-IL-6 receptor. So all of these blocking of NLRP3, blocking of IL-1 would result in low IL-6. However, if you miss that and you're now late in disease, the option exists for blocking IL-6 directly with the IL-6 receptor antibodies. There's also another option of IL-18 binding protein, which is important in macrophage activation syndrome. And actually, IL-18 binding protein is available clinically. It's used for macrophage activation syndrome in special people with a mutation. There's also direct anti-gamma interferon to inhibit macrophage activation syndrome. Again, this is very late. And some new information about JAK kinase inhibitors that are used in autoimmune diseases. But on the top of the list is actually NLRP3, which is the target of early intervention. If we can intervene early and stop the cytokine storm early, we may prevent the induction of other cytokines. And what sometimes takes place in the disease is the cytokines induce more cytokines and you get into an autoinflammation vicious circle. We know that NLRP3 is activated by COVID-19. All the coronaviruses seem to activate NLRP3. Many papers on this topic. So we know that there's a direct activation that takes place. Now, what is available to specifically inhibit NLRP3 in humans? At present, there's only one clinically used specific NLRP3 in phase 2 trials. The chemical name we use is OLT1177. Generically, it's called Dipancetril. It's a small synthetic compound, orally active, and it's safe in 3 completed clinical trials. One phase 2 trial has been completed in acute gout flares, and another has been completed in heart failure, and the phase 1 study in healthy volunteers has also been reported. Now, the paper, the study with the oral Dipancetril was just published on April 7th in Lancet Rheumatology, and it is a publication that reveals the ability of an oral NLRP3 inhibitor to reduce the severity, pain, joint swelling, etc., of an acute gout flare. And I just want to show you that the oral drug, actually met its primary endpoint. And the primary endpoint was day 3 of the acute gout attack would be reduced by greater than 50% of the VAS scores, the visual acuity score for pain. And so you can see for 2,000 milligrams on day 3, it was statistically significant reduction in the VAS scores. And at 1,000 milligrams, it was significantly reduced by day 7. But also the 300 milligram dose, we see efficacy in day 3. If you compare oral NSAIDs, high-dose NSAIDs, or oral steroids, you get the same 50% reduction at day 3. So an oral NLRP3 inhibitor accomplishes the same clinical efficacy of high-dose steroids or high-dose NSAIDs in acute gout. And clearly, it's considerably safer than high-dose steroids, particularly for people with kidney disease, and particularly safer for type 2 diabetics to use steroids. And it's actually an important consideration when we think about who the patients are who succumb to acute gout attacks. During the trial, however, we noticed that the neutrophils dose-dependently decreased on day 3. You can see that the 2,000 milligram dose had the greatest reduction. It was a clear dose response. And if you look at the IL-6 levels on day 3, there's a 72% statistically significant reduction in circulating IL-6 on day 3 in these patients receiving NLRP3 inhibition. Again, I want to remind you this is oral, and it accomplishes several of the aspects that we consider important in acute inflammation, which is obviously pain, but also reduction in neutrophils, which is completely objective, and reduction in circulating IL-6, which is completely objective. Now, the most important trial of Dupixent trial was actually in the target population of patients similar to the target population of high-risk patients with COVID-19. That is, people with heart failure, diabetes, and obesity. This was a trial conducted by Antonio Abate at the Virginia Commonwealth University, a close colleague of ours. It was 14 days of oral Dupixent trial in patients with systolic heart failure, type 2 diabetes. It was a double-blinded, dose-escalating, randomized trial. And the significant improvements in the high-dose cohort, which is 2,000 milligrams, similar to the 2,000 milligram per day in the gout trial, was a statistically significant increase in left ventricular ejection fraction, increased treadmill exercise, fasting blood glucose values were normalized, IL-1 beta and IL-18 plasma levels fell. So it actually was very successful in the same population that we believe is high risk for COVID-19 ARDS. Now, the treatment, once the cytokine storm begins, it may be too late actually at that point to deal with oral therapy. We're not sure if it would work as well as it would work early in the disease. We're left with two mechanisms, two therapeutic options. The first is anakinra, and the second one is neutralization with anti-IL-6 with tocilizumab. Now, in terms of the anakinra study, the Europeans are more advanced than we are. There's very big trials in Italy, in Greece, in Canada, New Zealand, even though they don't have very many cases, the United Kingdom, and an important consortium called REMAD for community-acquired pneumonia. In the United States, Sloan Kettering, Boston Women and Brigham's Hospital, Mount Sinai University, and other places are considering anakinra for acute ARDS associated with COVID-19. How does anakinra work? Well, how does IL-1 work? So IL-1 will bind to the type 1 receptor, which is on all tissues except red cells, and it binds the type 1 receptor. That causes the dimerization of the co-receptor called receptor 3, and that results in a strong pro-inflammatory signal. The IL-1 receptor antagonist, shown in the upper right-hand corner, structurally is very similar to IL-1. There's a high affinity for the type 1 receptor, binds the type 1 receptor, and prevents IL-1 beta or IL-1 alpha from binding to the receptor. So it's a pure receptor antagonist, and there's no signal, and it essentially shuts off signal transduction by IL-1 beta or IL-1 alpha. It's very effective in a variety of diseases. It's used in a variety of inflammatory diseases, and also it saves lives in macrophage activation syndrome. That's all published data. The question now is that anakinra can also be used in acute ARDS in patients with COVID-19. The consortium called REMAD for community-acquired pneumonia, REMAP, stands for Randomized Embedded Multifactorial Adaptive Platform Trial for Community-Acquired Pneumonia. It's a primarily European consortium. The United States is not part of this. They recently issued a special area for treating COVID-19. Generally speaking, REMAD-CAP for community-acquired pneumonia was targeting influenza, people in the intensive care unit with influenza-related pneumonia, and anakinra was the primary therapeutic option. The COVID-19 domain-specific appendix includes treating patients with one of three situations: no treatment, essentially standard of therapy, interferon beta, or anakinra. Now, why would anybody use beta interferon? The reduction, the use of anakinra is clear. It reduces I1 alpha and beta. But why the rationale for interferon beta? It turns out that interferon beta actually suppresses IL-1 beta. As you can see from these graphs on the slide, it's a very effective way of reducing IL-1 beta. So that's the rationale in the community-acquired pneumonia consortium, is to use either anakinra or beta interferon based upon the fact that beta interferon suppresses IL-1 beta. Personally, I'm not in favor of beta interferon because it is not well tolerated. Anakinra is very well tolerated. And the advantage of anakinra is that it's short-lived. It has to be injected every day. And that gives the physician a better control over the patient and the therapy, because for any reason there are complications, you can just stop the anakinra therapy and the drug is gone in 24 hours. A similar benefit of oral NLRP3 inhibition also is that you can stop the oral therapy and the drug is gone within 12 hours. A lot of people have discussed this issue of hydroxychloroquine. I don't want to really say much about this, except that this does about everything, but it's not particularly specific. It does inhibit IL-1 beta, but many of these drugs inhibit IL-1 beta. If it does work, and we're not sure it does, you'd have to entertain which of the multiple targets of hydroxychloroquine accounts for, if there is any therapeutic benefit in COVID-19, which of this list is applicable. The interest in JAK inhibitors is actually a little bit surprising for me, because we know that the mechanism of JAK inhibitors includes the inhibition of IL-1 and the inhibition of IL-18 and the inhibition of gamma interferon. It does about everything, similar to hydroxychloroquine. The difficulty I have with JAK inhibitors is the patients don't like it. It's sort of toxic. Comparing NLRP3 inhibitors, they're non-toxic. In fact, people on the gout trial and in the heart failure trial felt much better. There was no toxicity whatsoever associated, no side effects. So if you want to compare an NLRP3 inhibitor with a JAK inhibitor, you'll have to deal with the side effects that are quite well documented, including infection with JAK inhibitors compared to NLRP3 inhibitors. NLRP3 is very specific for IL-1 beta secretion. It really doesn't affect anything else. And JAK inhibitors affects a multitude of pathways. So I'm just giving you my impression of JAK inhibitors compared to, which are oral, compared to another oral drug, NLRP3 inhibition. Well, I want to finish by thanking Antonio Abate of Virginia Commonwealth University. He shared his not yet published data with us, so I could show it to you. And the most important thing about his trial in Richmond, Virginia, is the majority of his patients enrolled in the trial were actually African Americans who had refractory heart failure, high BMIs, and type 2 diabetes. And we all recognize this unfair and poorly understood prevalence of African Americans to succumb to COVID-19. But his population was exactly what we want to do, and that is to reduce the toxicity of the disease, the lethality of the disease in African Americans particularly. I want to thank Olitech for supporting the trials of Japan's trial in acute gout and the Abate trial in heart failure. And I have to disclose that I am the chairman of Olitech Scientific Advisory Board, and that my laboratory at the University of Colorado receives support from Olitech. And thank you.
Charles, thanks very much. We have a number of questions. I'm going to move from the general to the more specific. So a general question that I'm sure the speakers have some thoughts about is the issue of age and how age is such an important factor in terms of the morbidity and mortality associated with a coronavirus infection. But individuals that are older tend to have less of an inflammatory response. Try to put age as a risk factor in the context of the disease that we're seeing in the lung.
What we know about aging, expression that we often use these days, called inflammation, which is a combination of inflammation and aging. It's a characteristic of aging. We make more IL-6, we make more IL-1 beta, and so we are more inflamed as we age.
Yeah, I agree with that. That's what I mentioned, that it's known that the elderly people tend to have always already at the baseline, they have a little bit higher levels of interleukin-6 in the serum compared to the normal adult or younger.
Okay. We have a question about the vasculopathy that's occurring in these individuals and the microscopic thrombi that are seen in individuals with ARDS. How does that square with your ability to recruit alveolar ventilation through the various maneuvers? And also, what about the use of anticoagulation in patients, especially with high concentrations of D-dimers?
I think Ivor should answer that.
Ivor? You might be muted, Ivor.
Well, the only thing I can add to this is that IL-1 alpha is a product of endothelial cells. I showed a slide on this, but that the H2 is present on endothelial cells, and that will cause the release of IL-1 alpha. IL-1 alpha is definitely the problem with Kawasaki's disease, which is a vasculitis. So it's possible that an antibody to IL-1 alpha would reduce the vasculitis with vasculopathy. I can't comment on the anticoagulation, but people have a ability to anakinra. The anakinra blocks both IL-1 alpha and IL-1 beta. One of the benefits of anakinra is the ability to block IL-1 alpha.
David, if I can follow up.
Yes, go ahead, please.
Because for sure, I know it was not in the study that I present, but I know from another colleague of mine that some patients treated with tocilizumab, the ones that they have high levels of D-dimer, it goes down within a few days with the treatment with tocilizumab. So interleukin-6 is definitely, as I say, induced the production of fibrinogen, and it has also activities in the vascular smooth muscle cell too. So part of this, it could be through the interleukin-6, and definitely I know that for some of the patients from that time I've been treated, the D-dimer goes down very quickly with the treatment with tocilizumab.
Ivor, do you want to comment on the vasculopathy? Okay, let's move to the inflammatory response. And there have been several questions about the role of other inflammatory mediators, complement, for instance, and the vascular lesions that are seen, or metallopeptidase family proteins that cleave IL-6. Tell us how these other factors relate to the inflammatory response that we see, and also potentially to therapeutic options.
I can mention about the for the metalloproteases. Definitely, that would be one way to block the production of soluble interleukin-6 receptors. The only thing is that we don't know so far if it's just the soluble interleukin-6 receptor or the membrane-bound interleukin-6 receptor too. So in that case, you would primarily block the effect of the trans-signaling. But unfortunately, all those inhibitors that have been done are relatively toxic because they will inhibit ADAM 10 and ADAM 17 are involved in many processes. So I think those will be probably hard. I haven't heard much about complement, and none of these studies actually show up in terms of signs of complement activations and in together with antibody. But I haven't heard much. But with the proteases, definitely it could potentially be an option, but I think the inhibitors are not pretty good because the systemic effect.
Charles, do you have a comment on complement?
The complement induces IL-1. That's case all over.
Mm-hmm. Let me switch the questioning to the at-risk population. It appears that Ivor Douglas has been disconnected and needs to be reconnected. So if Paul Herndon is on, please try to reconnect Ivor Douglas. Let me ask a question about the at-risk population.
And David, I am back on, thank you.
Oh, very good. Okay, maybe you have a comment on the vasculopathy.
Yeah, thanks, and I beg your pardon if I couldn't respond right away. The issue is really key. This is issue of thromboinflammation, if it is a driver, is a big challenge from a propagation of clot perspective. And I'll give a couple of clinical observations. Although not formally reported, there are an emerging understanding that venous thromboembolism is occurring at a spectacularly high rate. In fact, we have had a patient at Denver Health with a saddle embolism, even after they were transferred out of the ICU, despite prophylactic levels of low molecular weight heparin. This has led many to believe that in a selected group of patients, aggressive procoagulopathy is part of the disease. And some clinicians are actually treating with full systemic anticoagulation. We are not. I will say that there is real interest in using TPA as a nebulized therapy, as a kind of a bailout approach for patients who have very severe hypercytokine storm syndrome with coagulopathy and fibrin degradation shutdown. And so Jean Moore and the co-investigators who have a lot of experience in sepsis-associated coagulopathy are leading that. You asked the other question, which is much more challenging on a day-to-day basis, and that is how to recruit patients with PEEP and other strategies when the primary disease is not an airspace one. And this really is a specific challenge when it comes to the prone position and high levels of PEEP, because the risk is that the already open segments of the lung could become over-distended, thus worsening regional shunting and amplifying the level of gas exchange problems. That has not been our experience in practice. And in fact, we believe that cautious recruitment strategies, prone and moderate to high levels of PEEP, are actually creating a more homogeneous VQ relationship across the lung for reasons that have to do with balancing the pleural pressure gradients. And in fact, that the application of these strategies, when combined with prone position, are not as lethally dangerous as other people have raised concern about. We continue, obviously, to have interest in exploring that mechanism.
Okay, thank you, Ivor. Let's move to the at-risk population. We are observing that African Americans have a higher prevalence of this disease and have more severe disease. We also see the severity of the disease associated with a variety of comorbidities. The question is, what potential genetic factors that are either associated with these populations or associated with other comorbid processes could be at play here? What about CFTR or alpha-1 antitrypsin? Mercedes mentioned receptor polymorphisms in the IL-6 receptor. What about HLA genotypes? They've been previously associated with SARS and MERS.
So I'm going to talk just for the interleukin-6 is this polymorphism that I mentioned that is in the promoter, that the minor allele, it results in less interleukin-6 production. In the overall population, again, based on, this is like all the studies, it was about maybe 20%. Based on some studies, the incidence of this, the prevalence in the African American population is much lower, meaning the interleukin-6 levels probably could be higher in the African American. So based on in some of the studies are not really, like large cohort, but it almost suggests that the prevalence of this polymorphism is less than like a 1% relative to 20% to the rest. But again, I'm not going to say exactly because there were no like a big studies.
David, could I respond? And it's part with a response and part a question for Dr. Dinarello. It has a lot to do with the decades of disappointments in treating both sepsis and septic ARDS with targeted anti-cytokine therapy. And while there are many reasons that derive from study design that have possibly led to that, and a lack of careful subgroup selection, what's absolutely clear is that the redundancies in cytokine signaling networks, shown just beautifully by Dr. Dinarello specifically, have led to frustrations in that targeting one particular aspect of a pathway is insufficient to shut down the primary pathophysiologic driver of inflammatory disease. So voicing my skepticism doesn't mean I don't have interest, but I am just to get Dr. Dinarello's perspective.
Charles, why haven't we seen success?
Well, there has been success in subgroups, and of course, the difficulty, of course, is the heterogeneity of sepsis. But I just want to address one thing that's very applicable to what we're dealing with now. The high ferritin, the use of blocking IL-1 in macrophage activation syndrome, unrelated to COVID-19, is quite dramatic. I mean, Randy Crone was interviewed by the New York Times because of his expertise in blocking the hemophagocytosis macrophage activation syndrome. Now, in the big sepsis trial, the big 2,000 people that anakinra was used there, some of these people did not had classic macrophage activation syndrome. They had classic activation with D-dimer and everything, and their anakinra was dramatically and highly statistically significant improvement in all-cause mortality. So you can really say that in this particular disease, anakinra is a therapeutic for macrophage activation syndrome. I think that's why this consortium in Europe is using anakinra. Now, how many people in classic sepsis have macrophage activation syndrome? The French say 16%. I don't know. I have no idea where they get what that number is. But in this particular disease, if you do have a high ferritin, a high D-dimer, anakinra would in fact work, and I'm not so sure anti-IL-6 is any different, but for sure we know from the sepsis trials that anakinra did work for macrophage activation syndrome, and that's because anakinra reduces IL-18. Now, IL-18 binding protein would be a therapy, but that's really not available in the amount we need to do this. So we're back to anakinra. I still think the sepsis is so heterogeneous, but I'd like to just factor out those that really have macrophage activation syndrome and treat them differently.
Okay, thank you. Let me ask a final question, and this has to do with our healthcare workers, our physicians, NP, PAs, and nurses who are exposed to patients with coronaviral-induced ARDS. What is their risk in terms of exposures, especially as it relates to aerosolization of the particles, the viral particles, as a result of nasal oxygen, CPAP, BiPAP, and aerosolized therapies?
Yeah, so I think that the risk is both measurable and very wide in terms of frontline workers. What's the data that we have? We have a little bit of data about particle distribution and persistence in still air on surfaces of a wide spectrum, copper, iron, steel, materials of different varieties. And the bottom line is the virus, even in environments where slow deactivation occurs, such as a UV, is slow, thus representing a high level contact and aerosol inspiration risk. The real concerns for our providers up front are in fact around procedures that generate aerosols. So let's think these through. In the patients we spoke about today, that would be things like intubation, any form of positive pressure administration to the airway, whether it's through an endotracheal tube with a leak, through a face mask or high flow nasal oxygen. And as I discovered this week when I was putting in a chest tube, it was pointed out to me that just the matter of opening the chest wall is very likely to generate a large spray of aerosolized particles. The further concerns apply to procedures such as tracheotomy, which has become a point of some contention, in that we have patients, many patients on ventilators now, ready to perhaps move to a prolonged stage of ventilation, who are stuck with an endotracheal tube because there's a reluctance, I think reasonably, to perform tracheotomy on those patients. And then the last is about surface contact, and that has everything to do with the care of doffing more than donning the PPE, and then going home. And I really think that that's an area that remains unexplored. And obviously there's some guidance that I know, David, your office and others have put out surrounding the caution and care required for personal hygiene, protecting our families.
Yep. Ivor, thank you very much. And Drs. Rincon and Dinarello, thank you for your great talk and the discussion period as well. Next week, we're going to be discussing medical ethics as it relates to COVID-19 infection. We're going to be talking about rationing, end-of-life decisions, as well as palliative care. Thanks a lot for joining us.
Thank you. Thank you, David.